Welcome to this session. I have clarified the concepts of basic optics in refractive errors in the A part of this sequence. In the B part, that is this presentation, I will talk about the clinical presentation of refractive errors, and in the C part, I will talk about the treatment of refractive errors. For now, let us proceed with the clinical presentation of refractive errors. I have talked of the etiological types of ametropia in the basic optics parts of this series. Coming to the clinical types, hypermetropia may be simple, also known as physiological or developmental. It may be non-physiological or pathological, or it may be functional. Simple hypermetropia is the commonest type and is the result of normal biological variation in the development of the eye. It is usually mild, less than +2 diopters, to moderate, +2 to +6 diopters, but rarely may be high, more than +6 diopters. Simple hypermetropia in children tends to gradually reduce as the eyeball grows. In non-physiological or pathological type of hypermetropia, anomaly lies outside the limits of biological variations. It may be congenital, as in microphthalmos, or it may be acquired, as in aging-related decreased curvature of the outer lens fibers, cortical sclerosis of the lens, change in refractive index of the lens, posterior subluxation of the lens, aphakia, pseudophakia, or surgical overcorrection of myopia. These days, aphakia is not so commonly seen, as we usually do not leave the eye after cataract surgery without an intraocular lens implant. And hypermetropia in pseudophakia and surgical overcorrection of myopia is also not so common. Now, functional type of hypermetropia is seen in paralysis of accommodation, as in third nerve palsy. Let us look at the fundus findings that we get in hypermetropia. A hypermetropic eye is a small eye. Per diopter change in the power corresponds approximately to 0.3 millimeter change in the axial length. As a result of the eye being small, the structures in the fundus and the eye in general are more compactly arranged, and as a result we get a disc which is small, hyperemic, and has ill-defined margins. It resembles the disc of papillitis, and it is also called pseudopapillitis or pseudoneuritis. The background retina has a shiny appearance called the short silk appearance, and the vessel reflexes are accentuated. Clinically, myopia may be congenital, simple, this is the commonest type, it may be high progressive, or secondary. Congenital myopia is relatively less common. It is present since birth. It's usually unilateral, maybe bilateral. Most of these patients therefore have anisometropia. The error is high, about 8 diopters or more. It is almost constant. Excessive viewing for near may lead to a convergent squint. One must be aware of this not so common presentation of myopia, for a unclearly visible fundus in a small child may be misdiagnosed as a patient suffering from vitreous hemorrhage. Simple myopia is the commonest type of myopia. It is considered to be physiological. Axial and curvature type of simple myopia is a result of biological variation in the development of the length of the eyeball. There is no conclusive evidence regarding role of diet. Genetics plays some role. as one or both parents of these children are often seen to have simple myopia. It is not associated with any disease of the eye, mostly begins in the school-going age of 5 to 12 years. It is therefore also called school myopia. It increases slowly till the age of 18 to 20 years. The error usually does not exceed 6 diopters. High progressive or pathological myopia, as the name suggests, starts in childhood and progresses rapidly to high myopia, more than 6 diopters, maybe 10 to 20 diopters in adulthood. It is associated with degenerative changes in the retina and vitreous. It is less common than simple myopia. The patient has prominent eyeballs with large cornea and deep anterior chamber. In high progressive or pathological myopia, there is increase in the axial length of the eyeball, which leads to a large optic disc and an outward bulging of choroid and sclera called the posterior staphyloma. Other than this, there are several degenerative changes such as peripapillary atrophy, temporal crescent, sometimes a nasal crescent, chorioretinal atrophy, degeneration and Foster-Fuchs spot at the macula, peripheral retinal lattice degeneration, and degenerative changes in the vitreous. These are illustrated in figures 2a and 2b. These are pictures showing fundus changes in high progressive myopia. So here you see peripapillary atrophy. There is a temporal crescent here as well as here. Sometimes there is a nasal crescent. There is a large optic disc and there is macular degeneration. Sometimes there is a macular hemorrhage, which is called a Foster-Fuchs spot. There is chorioretinal atrophy, which leads to the appearance of a tessellated fundus. In the periphery, there are degenerative changes in the periphery. This is peripheral lattice degeneration, and these have to be specifically looked for. Otherwise, they may be missed on a routine examination, and if necessary, they need to be treated to prevent further complications. Here we see the bulge of the posterior coats of the eyeball. Try to appreciate the parallax between this part and this part of the fundus. And this can be also illustrated on a B scan. Look at this bulge. This is a posterior staphyloma. Certain complications are associated with high progressive myopia. They are retinal detachment, complicated cataract, vitreous hemorrhage, and choroidal hemorrhage. Retinal detachment may be prevented if the peripheral retinal degenerations are treated. Astigmatism may be irregular or regular. In irregular, there are no clearly defined axes as seen in irregular or scarred cornea. In regular, the two axes can be identified. The regular astigmatism may be simple, in which one axis is emmetropic and the other is ametropic. It may be simple myopic or simple hypermetropic. Or compound, where both axes are either myopic or hypermetropic, and mixed, where one axis is hypermetropic and other is myopic. These are illustrated in figure 4. Here we see simple myopic and simple hyperopic astigmatism. The one axis here is emmetropic, same here, one axis is emmetropic. Then we have compound myopic and compound hypermetropic astigmatism. Both the axes are myopic or both the axes are hypermetropic. And this is mixed astigmatism. One axis is myopic and the other is hypermetropic. Presbyopia is a natural process of aging of the lens, leading to gradual loss of its elasticity, along with the ability to change shape to accommodate or focus on near objects. Though the gradual loss of elasticity begins in childhood, as shown in figure 6, it usually becomes clinically noticeable as difficulty in near work in early to mid 40s and continues to worsen until around age 65. Here we see in a normal, that is non-presbyopic eye, when the individual tries to focus on a near object, the ciliary muscles contract, the lens becomes more convex to focus the near object image on the retina. Whereas in presbyopia, the lens has lost its elasticity and hence is unable to change shape, and therefore it is unable to focus the image of a near object on the retina. Instead, it gets focused behind the retina, and in order to bring it to the retina, a presbyopic individual needs correction with the help of convex lens. This figure shows the accommodation curve in relation to age. The B graph is the average values, the A graph shows the highest values, and the C graph shows the lowest values. Now looking at this, the average accommodation in diopters is about 14 diopters in children, and the lower values are about 12, the higher values are about 16 to 17. Gradually this accommodation goes on decreasing, and by the age of 40 to 45 years it starts becoming symptomatic, and this gradual decline in accommodation goes on, and at the age of about 60 years this graph flattens. The symptoms of ametropia are variable. They depend upon the age, amount of refractive error, the accommodation amplitude, individual's desire and effort for visual gain, and his susceptibility. They may be one or more of the following. Eye strain, also known as asthenopia, is due to continuous effort to obtain a clear image. Poor vision for near, distance, or both. Instead of complaining of poor vision, very small children may have symptoms of frequent eye rubbing or avoiding distance or near work. Muscular imbalance due to disbalance between accommodative effort and convergence. If allowed to remain untreated in early childhood, may lead to functional suppression of vision called amblyopia. Let us try to understand the symptoms of hypermetropia. An hypermetropic individual uses excessive accommodation for distance and near. If he gets clear vision on using excessive accommodation, he continues to use excessive accommodation. As a result, develops eye strain and headache. And this accommodation convergence mismatch in a susceptible individual develops accommodative esotropia. If he does not get clear vision or does not have much desire for clear vision, he gives up using excessive accommodation, continues to have poor vision, and this leads to development of unilateral or bilateral amblyopia, also called the lazy eye. Unlike a hypermetrop, a myope has to use lesser accommodation or relaxes accommodation. For distance, he has to relax accommodation, and if he gets clear vision, he continues to relax accommodation. This may lead to eye strain and headache. It may also lead to accommodation convergence mismatch. If he does not get clear vision, he complains of poor vision for distance, or sometimes squeezes his eyes to get a pinhole effect and a clearer vision. For near, he needs to relax or use lesser accommodation. He can see clearly for near, he may have to bring objects even closer. This again may lead to accommodation convergence mismatch, and in a susceptible individual may lead to development of exodeviation. As a myope can see clearly for near, he is less susceptible to development of amblyopia. The symptoms of myopia. Parents complain of the child holding the book or mobile at a close distance, preferring to move closer to the TV or squeezing the eyes. There is difficulty in distant vision, like seeing the blackboard, and there is poor interest in outdoor games. There is progressive decrease in vision and increase in glasses power. The degree of increase in power is up to 6 diopters or less in simple myopia and much more in high progressive myopia. A myope has good vision for near, hence is less prone for development of amblyopia. Constant use of lesser accommodation and thus lesser accommodative convergence may lead to an exodeviation. Exodeviation is much more common than esodeviation, which may occur in some myopes due to constant preference for doing near work at a closer distance. We have seen in basic optics that in astigmatism, use or relaxation of accommodation may help to relieve image distortion but not the blur. Thus, a person with astigmatism complains of blurred vision, eye strain and headache. Untreated astigmatism of more than 1 diopters in susceptible children may lead to meridional amblyopia. An isometropia may be simple when only one eye is emmetropic and the other is ametropic. Compound when both eyes have different degrees of same type of error. Both may be myopic or both may be hypermetropic. Or mixed, also known as antimetropia, where one eye is hypermetropic and the other is myopic. Either of these may be associated with astigmatism. Symptoms depend upon the type and amount of refractive error. Usually there is eye strain, difficulty in near or distance vision, or both. When the degree of anisometropia is more than approximately 2 diopters, there may be difficulty in binocular vision due to image size discrepancy, also known as anisoconia. The hypermetropic eye is more prone to develop amblyopia, and susceptible individuals may develop microtropia or small degree squint. Presbyopia is due to age-related decline in the capacity to accommodate. Symptoms of difficulty in near vision appear at the age of about 40 years and continue to worsen until 65 years age. As there is blurred vision at normal reading distance, there is a tendency to hold reading material farther away to see the letters clearer. There may be eye strain or headaches after reading or near work. Symptoms are worse when fatigued or working in dim light. Due to the difference in accommodation need in various refractive errors, the symptoms appear earlier in hypermetropes than in myopes. In undiagnosed myopes, symptoms may not be apparent till very late. This gives them an opportunity to boast that they do not require any reading glasses when most of the people of their age are unable to do without reading glasses. They attribute it to their better eating habits and better health. Let us now revise and also test our understanding of the clinical presentations of refractive errors with the help of MCQs.